The big C, cancer. It's a word that no one likes, but many patients hear. The diagnosis of cancer heralds a profound moment in the life of any patient. But with this disease, one size doesn't fit all. The word cancer might make you think of a desperately ill patient lying in bed. Or you might think of Lance Armstrong winning the Tour de France. This two-time Olympian had an advanced form of testicular cancer that spread to his lungs and brain. The simple fact is that while it's a serious concern, a diagnosis of cancer can mean different things. From bone cancer to brain and breast cancers to leukemia to skin cancer, this disease comes in many forms. Some are deadly, but many are far less severe. With good treatment, the prognosis can be quite positive. What is the disease we call cancer? Can it be prevented and treated? Will there be a cure? And how can survivors, their loved ones and friends cope with cancer? Hi, I'm Rich Krieg, host of On the Horizon, and with me in the studio today are Darlene Miller, chair of the Claudia Mayer Cancer Center, Dr. Clement Knight, an oncologist, and Dr. Jeanette Linder, an oncologist. Welcome to On the Horizon. Dr. Knight, let me start with you. What is cancer?
Well, cancer is basically a disease or disorder characterized by growth of cells that are uncontrolled. These cells are obviously cells that are derived from the person or the patient's own body. Therefore, the immune system doesn't appear to be involved in trying to control or reduce the growth of these cells. And generally, there's an overgrowth of cells which results in either a local compression of various organs causing illness, or dissemination, or we call metastasis, to various parts of the body, causing damage to various organs and tissues, usually resulting in death.
All right, and let me let's just take the words carcinoma and sarcoma. Let me ask you what those two are, and then we'll just go down the table.
Certainly. A sarcoma is a cancer derived from certain tissues called mesenchymal tissues, and a carcinoma is usually derived from certain tissues that are more lining of organs. So basically, they're all malignancies, but sarcomas are, let's say, of the muscle, of the soft tissues, and carcinomas are more of the lining of organs like the stomach or the esophagus or the intestines. So it's basically a differentiation of the sites of origin of the tumor.
Okay. And Dr. Linder, why don't you take leukemia and lymphoma? These are words that our audience hears, and why not describe what those are?
Well, leukemias and lymphomas are actually very confusing to a lot of people because they can appear very similar, but they're diseases of the hematologic system, or the blood system, the bone marrow, the lymph nodes. So leukemia is when you have the abnormal cells circulating in the blood system, and lymphomas have the malignant cells collecting in areas either within lymph nodes or the lymph glands like the spleen or the thymus, or in other parts of the area where it's a large collection of malignant lymphatic cells.
Okay, and Darlene, it's clear that there's not one disease entity called cancer, same size fits all, but it's different for different people. Yet when people come down with this, it's a profound issue for anyone. What's it like to get this word that you have cancer, and in your case, you talk quite openly that you are a cancer survivor?
That's right, Rich, and I have to say that I think hearing that diagnosis is one of the life-changing events certainly in my life, and although it doesn't necessarily have to be a change for the worst. It is very overwhelming. Luckily here in Howard County we have wonderful doctors and a great hospital and a lot of support for patients who, like me, are starting off on a journey that they have no idea where it will take them.
And in this theme that cancers are quite different in terms of severity and type, we talk about staging as a way to sort of evaluate the level of cancer, but why not, let me ask the two oncologists, and I know you're also a hematologist, you have other specializations in medicine, but how is it that you determine the severity by and large in general?
Well, the stage of the cancer is basically how extensive the cancer is at presentation. In other words, a stage 1 cancer is usually localized. A stage 2 cancer has spread to one particular other area. Stage 3 cancer is usually a few more areas, and stage 4 cancer is when the cancer is spread to involve an organ site other than the organ of origin, For example, if it's cancer began in the lung and it's gone to the liver, that would be a stage 4 or metastatic extension of the tumor.
Now, when that lung cancer goes to the liver, that's still a lung cancer. I think a lot of people don't realize that.
That is very important to determine, because most patients who come in say, oh, my mother's got liver cancer, and find it difficult to understand that the cancer in the liver the cancer cells in the liver are derived from the lung cancer, and therefore it's lung cancer which is spread to the liver and not a primary liver cancer, because the treatments are very different.
And Dr. Linder, the process of diagnosis is a process. It's not just yes, no. Could you comment a little bit about that, of how that process typically goes, knowing that so much in this area is atypical?
That's a great question, because that's what frustrates patients and families so much, because they think, okay, I got my diagnosis, now let's do something about it. Then they come see me, or they come see Dr. Knight or somebody else, and they say, well, first we have to stage you. And for different diseases, that may require 3 or 4 additional tests. And the common question is, well, my PET scan was negative, why do I need a biopsy? Or my CAT scan was fine, why do you need to do this other thing? And they get very frustrated, and they feel like we're not really solving their problem. So we have to educate them and help them understand the process behind it, and not just hand them the prescription and send them on their way. So this will help us adequately stage the 3 main ways that tumors grow. And that is the TNM system that the cancer societies all use.
Tumor
node metastasis, exactly. So T would be where the tumor begins in whatever organ is, whether it's a prostate or breast or lung. You want to see whether it's a certain size, whether it's going into adjacent organs, and then N, whether it's gotten into the lymph nodes. And there are lymph nodes all over our bodies, but the ones closest to the organ that has the cancer in it are the most important. And they can act as little filters, just like a swimming pool filter with the fluid going in and out, catching the bugs in the leaves. Bugs would be like infection, leaves would be like cancer cells, same sort of thing. So if you can identify that it has never gotten to the lymph nodes, then you can reassure the person. So that's one way to tell them, we need to keep doing these tests so we can help you understand how likely this is to be confined or spread. And M is metastasis, whether it's gotten into the bloodstream. And different tests will evaluate each one of those in very different ways. So we have to keep kind of reassuring these people that eventually you will get to some treatment where we're helping you.
And with a solid tumor, that method of staging is probably more accurate, but there are even more levels like 2A and B depending on the type of cancer.
Yes.
Let's discuss a little bit here the range of services available for people in the area of cancer treatment, prevention. Why don't we start and go down the table, ending up with Claudia Mayer. I know both of you sat in the same hallway, but describe, if you will, the scope of service provision for cancer here in Howard County.
Well, we have full service treatment from both conventional standpoints, radiation therapy and chemotherapy, and we also have clinical trials available with more advanced treatments that may not be available at your average center. So we do have access to a wide variety of clinical trials, both looking at high-tech treatment as well as high-touch, taking care of the entire family. We have a program called the Caregiver Study. This acknowledges how hard it is on everybody. We're really focusing on the primary caregiver because we can't spend time with all 30 members of the family, but we're really acknowledging how difficult this is from start to finish, even when things go perfectly well. So in our particular part of the building, we have the advantage of having this synergy with the medical oncologist next door, where we can have little mini tumor conferences all day long, where we want to see a patient and I just go and I say, hey Clem, I saw this patient, what do you think about this? And we get things done very quickly without having to go building to building or making a lot of phone calls.
And that's important because you have sort of a multidisciplinary look at that tumor rather than just one practitioner saying it's this or that.
We do. And then we also, from the radiation standpoint, have multiple modalities available. We have prostate brachytherapy done over at Howard County General Hospital. That's prostate seed implants. And we have other forms of prostate and other implants done down at our main center down at University. We have conventional external radiation. We have three-dimensional external radiation with CT planning, and we will be getting our own CT simulator in the next few months as well. And then we have intensity modulated radiation therapy and a wide variety of other things at our other facilities.
High-tech stuff, but as you're saying, with the softer hand-holding and support that the families can give. Would you add anything to that range?
Yeah, I'd like to add the fact that we do have a tumor board. In fact, we have two tumor boards. We have a breast cancer tumor board, then we have a general oncology tumor board, which basically meets once a month, sometimes twice a month, to discuss difficult cases, to get opinions from other doctors concerning the particular patient and their tumor. And our pathology department is part of the Johns Hopkins University Pathology Department, and they're a very strong pathology group, and they tend to get opinions very frequently from the Johns Hopkins Pathology Unit. Therefore, all the pathology, I know patients often have a problem with, are we sure we've got the right diagnosis, etc. Any pathology sample is always double-checked by two pathologists in Howard County Hospital, and opinions are obtained from outside hospitals, especially Johns Hopkins Hospital.
Excellent.
So the pathology is always double-checked, and I'm not saying it's infallible, because nothing's infallible, but certainly we make our best efforts to get the appropriate diagnosis, discuss the case at tumor board, and to discuss the management plan for the patients.
Okay, excellent. Darlene, could you lay out the scope of things that the center provides?
Sure. The center started about 5 years ago as two diverse ideas. One was to have a salon and image center for cancer patients, primarily women who were losing their hair, having skin issues, things like that. And the other coming from another individual who was a journalist who came down with breast cancer and was driven to find out everything she could about her cancer. And at the time, if you think back 5 or 6 years ago, we were not quite as savvy on the internet, and that was a little more difficult to do. So we really basically became an image and a resource center. And what we basically try to do is help and support the cancer patient in a non-medical, non-clinical setting. We have a salon that provides them with wigs and styling supports and makeup and skincare. And then we have a very, very large resource center that has magazines, books, videos, and an online service so that people can come in and have links to sites that are medically reputable and kind of facilitate that activity for them.
I think one of the things that people in the audience probably are thinking about is if I have someone in my family who has cancer, or a friend or a neighbor, how should I react? I realize it's all over the map, but in general, can you give some guidance to people? Let's say I have a friend who, and I know that he or she has cancer. What sorts of guidance would you give to people?
Well, it's interesting, Rich. Actually, we serve as many caregivers and family members and friends as we do patients. They come in and look at our resources. Our doctors and oncologists and radiologists here in the county are wonderful, and their nursing staffs are wonderful. The family and friends have a harder time getting the kind of information, or they feel it's not their place to ask questions. So we do get quite a few of them. As a cancer patient, I always tell people who will say, I just don't know what to say. You do have to take your cue from the patient. I find that more cancer patients like talking about their cancer than you might think. One of the things that happens when you're diagnosed is you feel different. You're suddenly labeled as a cancer patient. This sort of supplants everything else you ever were. You know, I used to be someone who worked for the arts festival. Suddenly I had colon cancer, and that's what I became. You have to adjust to that. And so I think people being open and honest and taking their cues from the patient will work very well. And I would assume that that's also what doctors do, in taking their cues from the patient and figuring out how much they want to talk about it and how much they want to know, quite frankly.
Jeanette, could you comment on that from the medical perspective? How important is the family and community support for a patient?
Well, she summed it up great. I mean, she totally gets it from helping the caregivers, being a caregiver, being a patient, and it's so individual, but the big thing is loneliness and fear. And secrets are very hard to keep. There are some patients who need to keep a secret, and you need to respect their wish to not discuss it. But they are very few. Most people really do feel better when they get these secrets out. It's not our job to get it out, but it's our job to help them feel like they have hope, realistic hope, and that they can talk to somebody and they don't feel so lonely about it. And the best advice that I give to caregivers is treat them like you used to treat them. And ask them what you used to ask, and try to help them be as productive in the family as they used to be. If they were the person who made the main decision about what to buy, you go ask them, as long as they're able to make those decisions, and let them keep their usual roles.
Okay. Clement, Darlene mentioned that. I think it was a journalist from the Flyer made it her business to learn everything that she could about cancer. As a rule, do you encourage patients to do a technical review of the technical literature, when they come down with cancer? Is that something that you see as beneficial in general, or is it best not to do that?
Well, it works both ways, really. I've had patients who've come in with stage 1 cancer, who have, prior to seeing me, have gone to the internet and looked up, let's say, colon cancer. And what they've read is all about stage 4 disease. And they come in very distraught, because a lot of these internet sites don't differentiate and don't actually categorize the stages. They just give you the worst scenario. And these patients come in sometimes very distraught, and until you tell them, excuse me, ma'am or sir, you know, this is talking about stage 4 disease. You have stage 1 or stage 2 disease. Stage 4 disease, colon cancer, is incurable under just about every circumstance, whereby stage 1 and 2 potentially curable.
I bet, Darlene, you're happy about that.
I'm very pleased with that.
And they tend to sort of take a big sigh and they sit down and start all over again. So it's very important. I do encourage people, but I tend to see them first, and I give them a website which I think is reputable. For example, the National Library of Medicine website. And I direct them as to what to look for. So they come back usually with 20 pages and say, I read all this, I don't understand this aspect, let's talk about it. And that's the way it goes. But I wouldn't recommend someone just going to some of those lay websites when somebody has colon cancer and decides that he or she wants to tell the whole world the story, and the patient's got stage 4 disease but doesn't even mention it in his summary that he has stage 4 disease, and people panic.
And the other thing, I suppose, is that there are a lot of myths out there that, and some of them widely held. Do you encounter things that just people get wrong over and over again?
All the time.
Could you mention some of those?
Will I glow in the dark? I can't hold my puppy dog anymore. My daughter's pregnant. Can I be with her? And the biggest thing is to treat it with respect, because it's a very reasonable question, but also reassure them and tell them that I'm not just a doctor, I'm a mother. And I understand that when I was pregnant, I didn't want to be around the prostate implant patients. It has nothing to do with the scientific fact that I was perfectly safe and my daughter was perfectly safe. It's because I'm a mother. So I understand that. And so we try to respect the intellect and the emotion at the same time, and really just educate them. We need to empower them so they feel like they understand what's going on and that they really truly are safe. Not just say, trust me, I'm a doctor, you'll be fine.
Right.
Have to really respect them.
Darlene, do you come across misconceptions of people coming into the Claudia Mayer Center?
We do, especially amongst family members and friends who don't have the access to the doctors and the first-hand information. And that's why we're so careful about the websites that we direct people to, and the magazines and books. It's very, very overwhelming. I was fairly comfortable in the medical environment, and it was completely overwhelming to me. So for someone who hadn't worked in healthcare, it's even worse. There are a lot of misconceptions, but interestingly enough, as a cancer patient, one of the interesting things I can pass on to people at the center and to things is it is not quite as bad as you think it's going to be. There's a myth that you're going to get chemo and you're just going to be in bed for 6 months and you're not going to be able to move and you're going to lose your hair, and you might as well just curl up and it's all over. I have a friend who was diagnosed a week before me with multiple myeloma, and as sad as that is for her, it was a wonderful blessing for the two of us, because we started actually talking to each other about every day, saying who had said something strange to you today, and we sort of collected them up. People really think you have to stop living the minute you're diagnosed. And my goal, and my goal in working in Claudia Mayer, is I'm not a medical doctor. I can't fix the medical problem, but I can help people live well with their cancer. And I'm 3 years post-treatment and cancer-free. I still consider myself living with my cancer, and I probably will consider that the case my whole life. I kind of deal with it like a chronic disease that I hope doesn't flare up. And that's very reassuring for me. But I think that's what we can do at Claudia Mayer, and that's what the doctors and the radiologists try to help us do, is to live well with the cancers. The days you have a good day, go out and have some fun. And the days that you don't feel so well, rest. But it's never quite as bad. And I've been a caregiver for some people who lost their battles with cancer. They have wonderful days, and our trick is to have as many wonderful days as all of us can, regardless of whether we have a disease or not.
You said some very important things there, and like you paired up with a friend early on, there really are a lot of support groups around specific types of cancer.
There are.
Could you talk about that?
There are. The American Cancer Society has quite a few programs. Reach for Recovery, there are breast cancer buddies. One of the nice things that's happening at Howard County General, and I know Jeanette's been involved, it's the new breast center coordinator, and Tina Bierman, who is a nurse, gets in touch with every biopsied patient who's biopsied at the hospital with their permission from their doctors, and reaches out to them and tells them she's there to be support and listen and do all those kinds of things. There are many support groups in the county. People are either support group people or they're not, but I think everyone needs someone. And whether it's a family member, whether it's a friend, whether, as in my case, it was all those people, whether it's a nurse in the chemo room who tells you what to do when your hands are burning from the chemo. We all need support. I think it's all about getting that cancer diagnosis, which is just immense, down to a manageable size for ourselves. A friend told me once, you want to get it down to something you can handle, and then you keep it in your pocket, and you bring it out when you have to deal with it. But I think that's what support's all about.
Okay, and I don't want to go too much longer without saying, how do people contact the center if they have a need?
We are at 5900 Cedar Lane, which is right next to the Howard County Health Alliance, and the phone number is 410-740-5858.
And I assume you want volunteers plus donations.
We want volunteers. We are funded through the Hospital Foundation, and we do a lot of fundraisers, and we are supported by Cuts Against Cancer. Our salon volunteers, we have 10 beauty salons in the county who support our patients, come in and deal with their wigs without charge. And every year they do a Cuts Against Cancer for us, and this year they raised $32,000 for us.
Okay, now we've established that we know that there are many types of cancers, but let me ask our two physicians, across those, what types of warning signs, what should the general public think about in terms of ensuring that they're doing the best job of diagnosing something that might be there? Tough question.
Well, it is tough because a lot of the things may seem like everyday problems. And so the first thing is to say, is this really an everyday problem? If you have an ache or a pain or a problem, if it doesn't go away, or it's a new problem when you've never had it before, go ask your primary care physician, call them up, make sure you get all your routine pap smears and your colonoscopy for your 50th birthday and your PSA routinely and other things, and understand that we do these tests to find them in the curable stage. Make sure you get your mammogram, do your examinations, and just pay attention to your body on an interval that's reasonable, every month or every couple of months, not every day. You'll create problems where there are none by checking too much, and then it's no longer helpful. Then it's a detriment to your health.
Okay, could you add to that?
Well, I quite agree, but I tend to advise patients to take a month of the year, ideally the birthday month. And for example, that month, that's your doctor month. Do you go and see your doctor for your routine health checkups, examinations, cholesterol levels, etc. And also your PSA, your mammograms if you're a female, the PSA if you're a male, think about colonoscopies. In other words, 1 month out of the year, if you spend a little more time with your doctor to ensure that the other 11 months you're sort of home free, it's the way to go. Because you don't forget then, your birthday month, get it taken care of.
Another time that has had some recent play is Thanksgiving. I think Francis Collins, who headed up the Human Genome Project,
yeah.
I think it might have been the Surgeon General as well, said in Thanksgiving, get to know your family history and specifically look back in terms of diseases that might be there. Is that something worthwhile to familiarize yourself with the disease track record of your family?
Very much so. I think about 5 to 10% of breast and colon cancers are hereditary. We know that. So if you meet at Thanksgiving, you talk about your family, and Aunt so and so had breast cancer at age 36, or premenopausal breast cancer. So it might impact all the children who are at that particular dinner or something. So it's very important, I think, to determine your family history, because it can be helpful.
Well, not looking at the past, but looking to the future, a lot of people say, will there be a cure for cancer? And you mentioned all that equipment and technical expertise, and certainly there are some improvements. But what's the future look like in general in terms of our getting something approximating a cure for cancer?
The main thing is early detection and prevention. Some things can truly be prevented to a certain degree, but then there's some of those genetic mistakes that occur in nature for no explanation that we're not going to be able to prevent happening. So we have to encourage early detection. When we figure out how to do that detection, there's some diseases that it's not reasonable to screen people for because it's uncomfortable and expensive and an uncommon thing. And so that phrase, there will be a cure for cancer, is a naive phrase. We would all love for that to be true, but that's not reality. So then we have to move on to better and better treatment, which we're getting. But if you talk to a patient whose cancer we're not curing, they're not going to buy that. There are still plenty of people who we are not able to cure, and so we have to make sure that we pay attention to helping them live as well as they can before they die as easily as they can. It's very complex.
That's true, but there are certain cancers which we are curing right now, I must say. We must be a little more optimistic than that. There's certain cancers, childhood leukemia, testicular lymphoma, testicular cancer, what's his name, Armstrong, the guy who just won the Tour de France again. I mean, he had cancer that had metastasized to his brain, and he's potentially being cured now. So there are certain cancers we can cure right now with our so-called blunderbuss chemotherapy that doesn't really select out a certain target organ, a target cell. But over the last few years, we've actually improved that quite significantly. We've actually got molecular targeting now. We've got a condition called CML, you may have heard of, chronic myeloid leukemia, where we have a drug, it's one pill you take a day, that goes in and turns off this gene product that produces leukemia. And based on that particular drug, many other drugs are being developed right now, which are targeted. We have drugs that inhibit blood vessel formation. When the tumor grows more than the size of a pinhead, it has to make its own blood vessels, otherwise it'll die from starvation. So we have these drugs now that can inhibit these tumors from making new blood vessels and thereby inhibiting their growth. We have tumors. We have drugs that inhibit certain molecular structures in solid tumors now that are impacting on the survival of those tumors.
Okay, exciting.
So we are making progress.
Exciting progress, and we have only a minute left, Darlene. Let me take the other side of this, the human dimension. If there was a woman out there who just had received a diagnosis of breast cancer, what advice would you give to that person? What would you say to a person who just received this news yesterday?
I would say you'll feel a lot better after you have a plan, and that's been outlined by your doctors, that it does not have to be as bad as you imagine it to be right now, and that there's hope, and there's help, and there's support out there. And reach out to people and get the help you need. And it will be a journey that will change you forever. And hopefully you will be well at the end of it, and live a very long and healthy and helpful life.
Well, on that very upbeat and appropriate note, let me thank Darlene Miller, Dr. Clement Knight, Dr. Jeanette Linder, and thank you for watching On the Horizon. We'll see you next time.